and CS. All right, so we're really excited today to have two speakers. The first is Andy Schweitzer. Is that pronouncing?
Schweiter.
Schweiter.
No worries.
Oh, I always pronounce it wrong. I'm sorry.
Always wrong.
Schweiter. Now I'm gonna remember that. He's awesome. He runs a language access services group here at the hospital, and he's going to tell you all about it. But it's really important information for us as we go into our ITT cases and be thinking through all the differences related to language access that our families may face. And I know we have two pretty run-of-the-mill white males this semester, but we're really going to try hard to get some diversity in our racial ethnic diversity in our cases next semester. So we really wanted you guys to have this lecture sooner than later, because you're going to see all kinds of families from all walks of life and backgrounds in your clinical experiences and through your other projects. So we wanted to have this information towards the beginning of Lent. So this first hour will be overcoming language barriers safely. And then we have Kristen Laswell, right? Okay, I got that one in the back. And she's going to come in about an hour and talk about health literacy and the importance of the way that we communicate with our families to make sure that we are, because we all know we use a lot of acronyms and a lot of jargon, right? So there's some great tools on Canvas and their slides are there too. So without further ado, thanks for your patience all with our technology today.
Awesome. I appreciate it. So yes, overcoming language barriers safely, because this is actually a formalist program. We do have learning objectives to let you know what it is we're talking about, the risks of working with ad hoc interpreters, and we can define all of that. Recognizing the collaborative relationship between providers or other employees in healthcare and professional interpreters, and accessing professional interpreters and translators at Cincinnati Children's. But before we do any of that, does anybody know why we provide services like interpreting and translation? Why do we provide language access?
It is a right.
Say more.
It is a right for the patients. I don't know the exact language to use with that, but basically you're entitled to use the language that you're feeling more comfortable with in terms of healthcare access and access to a lot of things.
Yeah, so it can be viewed as a patient right and getting to use your preferred language for interacting in healthcare. Yeah. What else? Why else do we do this?
It provides more thorough service experiences.
To provide a better experience for the patient or the employee?
For both.
Okay. Yeah, it's definitely better for patient and employee experience. Yeah.
Safety.
Yeah, for safety. If you can't communicate, it's going to be hard to provide safe care. In fact, it's going to be hard to provide care at all if you can't communicate with someone. So really, it makes it possible to do your job in a lot of situations to provide language access. But I want to make sure we recognize that legal point. We don't have a choice at Cincinnati Children's of whether or not we provide language access. The roots of this go back to the Civil Rights Act of 1964, which prohibited discrimination on the basis of national origin. Now, that doesn't apply to every company or every organization, but it does apply to those that receive certain types of federal funding. And so what happens here in language access is if you get federal funding for healthcare, then you can't discriminate on the basis of language. I'm pointing to the Affordable Care Act because there's a section in the Affordable Care Act, it's only about 2 paragraphs long, that says don't discriminate, follow the law. But that enabled the Department of Health and Human Services to expand that rule and say, what does this really mean in healthcare? So what it says is that any organization that receives federal funding for healthcare must take reasonable steps to provide meaningful access and provide qualified interpreters, qualified translators, or qualified bilingual staff at no cost to patients. You see that asterisk there? That's Medicare Part B funds, which are outpatient services, which are excluded because of political and historical reasons, which I am told have their roots in racism and discrimination. There is a current process happening to update this rule that would eliminate that exception and make a few other minor changes. So hopefully that happens. Other important piece about this law, it gives patients the right to sue, and the damages are not covered by malpractice insurance. Again, existing laws did give patients the right to sue, but it was kind of inconsistent. This pulls things all together in one place and also addresses the intersectionality that could be problematic there. For example, if you were discriminated in the past because you were deaf, you had to demonstrate a discriminatory outcome. But if you were being discriminated against because you were a woman, you had to demonstrate discriminatory intent. And that's very different standards to be held to. So this law kind of puts everyone on equal footing for discrimination in healthcare as far as what are your rights and remedies, so you don't have to try to figure out why you were being discriminated against. Questions about this before we move on? Those of you who work in places in the future that don't accept federal funding for healthcare may not be required to do this. That being said, it's still a critical aspect of safe and quality patient care. So I think if that's your organization's goal, you're still going to want to provide language access. At Cincinnati Children's, we do need to make sure that we follow the law, but I think we go well beyond that in many areas to improve the care we're providing. You know, what we're required to translate by the law is very small, and we probably translate somewhere in the neighborhood of 20 to 30 times that each year because we think it improves patient care and outcomes, even though we're not necessarily required to. We know that when you don't provide language access, there's worse quality of care, worse health outcomes, and worse patient satisfaction. That doesn't surprise me very much. What's interesting, though, is that even when we do provide things like interpreters and translators, there are still disparities, right? There are still increased rates of serious adverse medical events, including procedures done on the wrong patient, which almost happened here due to a language issue sometime in the last 2 years. Worse post-operative pain management, longer hospitalizations, more frequent ED reutilization, and generally poorer access to healthcare and suboptimal communication and family provider satisfaction. This is with language access, right? When we try our best, we still end up with disparities. So it's really important that we try our best because even that doesn't eliminate these disparities. Interpretation errors can have a pretty big impact. I don't think this is really surprising when you step back and think about if what you try to say isn't what the person hears, there could be a problem. One of the first very well-known situations that kind of kicked off this wave of language access in the 1990s was the Willie Ramirez case. He was 18 years old. He ended up with quadriplegia from a ruptured aneurysm and brainstem compression. When he came into the ED, the one word that the staff understood from what the people who were with him was saying was intoxicado. What do you guys think the medical team understood from that word? Like he was on drugs. That is how they treated him. He was misdiagnosed with drug overdose. In fact, he remembers waking up in the hospital, someone shaking him and saying, "What did you take? What did you take?" But that wasn't what the family was trying to say. What were they trying to say?
Incoherent.
Not that he was incoherent. Good guess.
Looks like he's intoxicated.
Not looks like he's intoxicated. We think he has food poisoning, is what they were trying to say. There was a new fast food restaurant. I forget if it was a Wendy's or a McDonald's or an Arby's that had just opened and he had eaten there earlier that day. And they thought that was the problem. And so the whole medical team was totally focused on this drug diagnosis and treatment plan when that's not what was happening. And that ended in a $71 million settlement and really helped raise the profile of the need for language access. But things like this continue to happen. So here's an example from 2002, 2003. A child fell off of her tricycle, fractured her clavicle. The resident was interpreting, and the mother explained how ella se pegó. She hit her shoulder on the road or on the sidewalk, but heard that someone had hit the child. This was also not the first time the child had had a fractured clavicle. So the team said, wait a second, I think there's some sort of child abuse here. Mom signed over custody of her 2 children due to that suspected abuse without understanding what she was doing. This was rectified within 48 hours, but is still a crazy traumatic experience that didn't need to happen. With trained professional interpreters, both of these could have been avoided. Any questions about either of these or anything we've talked about so far? All right. Then how is it that we provide language access? I've mentioned interpreting and translating a number of times. Does anybody know what those things are? Like, what's the difference between interpreting and translating?
I do.
Lisa?
Interpreting is like spoken language, whereas translating is written language.
Yeah, interpreting is that real-time spoken or signed communication support, and translation is that written communication support. I don't know about instant messaging and chat and stuff like that. That's obviously a gray area that didn't used to exist, but that's generally the distinction that you'll hear professionals making. When we talk about interpreting, supporting this real-time communication, how do we do that? You could have an interpreter in the room. Yeah, you could have that same interpreter on the other end of a phone or on the other end of a video call. So we do all of those things here, and those are all relatively common now. There aren't too many other ways that we connect trained professional interpreters in the healthcare setting. Which one of these 3 do you think provides a better experience for the clinical team? Like a better employee experience for the clinicians? Yep. Published research is very clear, totally in person. How about for interpreters? In person as well. It's interesting with the pandemic, it sort of shook that a little bit, right? Interpreters said, well, I'll feel safer if I'm at home. So you did see people shift to working phone and video. Some people found that they actually liked it and they did more of it. Or some people found that it paid better or they could be busier and therefore work longer hours and make more money. So there has been a shift, but there has not been a shift in what is a better experience for the interpreter, right? People are making the choice to work remotely, even though their experience is better when they're in person. An in-person interpreter can hear a lot better. Like, imagine a crying baby on the other end of a phone or in the room with you. It is so much easier when they're in the room to hear what someone else is saying. Interpreters can also position themselves better and move around the room. So generally, much better in person. What about for families? Better patient experience or better patient outcomes?
In person.
In person is everyone's hypothesis, but it has not been broadly demonstrated to be true. What is very clear is that qualified and trained interpreters provide a better experience and a better outcome than an ad hoc interpreter, like a friend or a family member or your high school Spanish or the janitor, which used to happen all the time in a lot of health systems. So what we need to remember is what we know for sure is that the professional is better than the ad hoc interpreter. And just because the professional is on the other end of the phone doesn't mean it's going to be worse than your high school Spanish because you're in the room. Does that make sense? Now, I think that in pediatrics, an in-person interpreter almost always leads to better experience and better outcomes. So here we are doing our best to provide in-person interpreters as much as we possibly can, especially when you have situations where lots of people are talking all at once, or the child speaks English and the parent don't, or one parent speaks English and the other doesn't. All sorts of situations where in-person is way better from my perspective, but that's yet to be demonstrated in any sort of peer-reviewed way. In the slides that Steph will share, I have 2 training videos linked here for you to check out. The first one we can watch a couple clips from. The second one is about 20 minutes long. It's great if you're interested in learning more about how to work with interpreters, especially remote interpreters. They cover a lot of really useful information in that. But if it's okay with you guys, I'd like to take a second to watch an interaction with an ad hoc interpreter. That sound good? So not a professional interpreter, someone who's there with the patient, serving as an interpreter.
Ms. Rodriguez, I understand that your religious beliefs don't allow you to accept a blood transfusion, but this is a very big operation. There's a significant chance of blood loss during the surgery. If you don't consent to a blood transfusion, I'm afraid it could result in your death.
Dice que la cirugía es muy grande y si no aceptas la transfusión de sangre te podrás morir.
Yo no voy a aceptar transfusión de sangre. Eso va en contra de mis creencias.
She still refuses the transfusion.
Well, maybe we could try blood products. Can you explain to her that if she has significant blood loss during the operation, we could give her platelets or albumin?
Dice que te pueden dar parte de la sangre. Eso te podrá ayudar a parar de sangrar.
Nada de eso. Eso va en contra de mis creencias. Ya lo dije.
Entonces le digo eso, que te deja morir.
Sí, dígale eso. Por si todo va a estar bien, ¿sí?
She said she would like that. She says that everything will be okay.
So she'll sign the consent for the transfusion of blood products?
Yes.
Okay.
Firma.
So what happened there?
And she wanted to like change the decision, so she translated whatever she wanted, but it was not the truth. And she forgot to mention like blood products, what are they, like how the doctor explained to the person. So it was like she was making decisions for the patient, and she was not supposed to do that.
Thanks. What else did you see?
A lot of it was lost in translation.
So things that were only said in one language weren't said in the other. Caitlin?
That was essentially
Mhm.
the patient still felt like the doctor didn't understand, like that she had beliefs, like that was the reason why she couldn't, but the doctor was validating. But that was lost in translation.
Yeah, not everything was said. So some of those messages didn't get all the way across. What else?
I think she also displayed some nonverbals instead of being like a blank slate is just translating what's being said. So like put her own feelings into it in a nonverbal way.
Yeah, so she may have been adding or omitting verbally and potentially non-verbally as well. Thanks. Anything else you saw? So in general, when you work with non-professional interpreters, you can see things like breach of confidentiality or reluctance to disclose information. Not that we really saw that here. Increased liability, but also additions, omissions, changes, misinterpretation, and potentially traumatizing children. So I don't know if that interpreter was the patient's daughter, but if she was, it's a very, very difficult position for her to be in. I'm not sure that any of the choices she had there would lead to a good experience for that ad hoc interpreter. When we talk about people who are not qualified interpreters, the law does have something to say on that. So again, this is applying to organizations that receive federal funding. It says that any organization that receives federal funding shall not rely on an adult accompanying an individual with limited English proficiency to interpret or facilitate communication, except in two narrow exceptions. First, an emergency involving an imminent threat to the safety or welfare of an individual or the public, where there's no qualified interpreter immediately available. Or two, when the individual with limited English proficiency specifically requests that the accompanying adult interpret or facilitate communication, the accompanying adult agrees to provide such assistance, and reliance on that adult for such assistance is appropriate under the circumstances. And the change that the Biden administration is working on would also add that this conversation is documented. Looking at that first exception, the emergency, is that going to happen at Cincinnati Children's for a language like Spanish? Probably not. Unless the phone lines are down and the internet's down, you're going to be able to get a Spanish interpreter, right? What about for a language like Pompeian or Kinyarwanda? A little bit more likely. You know, some of languages that are less commonly spoken, we may actually see this situation here, where you try to get a phone interpreter and it takes 5 minutes. We don't have 5 minutes in the trauma bay. That can totally happen. So there may be times where that does happen, but not for a common language. How about that second one, where the individual specifically asks this adult who's with them to interpret? Has anybody seen that before? How'd it go?
I mean, I just felt weird, like that. I don't know. I didn't feel very comfortable as a provider, like that what I was saying is really coming across. And like the other person in the room was just kind of like interpreting what I was saying and changing the language. So I didn't feel comfortable in that situation as a provider.
Thanks. Anybody else have an experience with it? So if we take your example then, did the individual with limited English proficiency specifically ask that this accompanying adult interpret or facilitate communication?
Yeah.
Okay, and the adult clearly agreed, because you can't force someone to do that. I think it's a weird part of the rule. Then the last part is it appropriate under the circumstances? That's a judgment call by the care team here. We add in our policy that it's generally not appropriate for consent or discharge. I'm guessing that's not what you were talking about though. But I think it's reasonable to say that if they're not interpreting everything, then relying on them is not appropriate. Because you're not able to communicate effectively with the patient. So that is a reasonable way to interpret this law and the policies that organizations like ours have written based on. That if that adult is not interpreting everything, that relying on them is not appropriate. So feel free in the future to address that. Steph.
I was going to get to this question of how do we address it? Can you give us some language around it? Because I know I've experienced where a mom is learning English and wants to feel confident in her English skills, so declines use of an interpreter. But I have concerns that I have no idea how to measure her understanding of the English language. And so I would rather feel safe by using the interpreter, but I also don't want to offend. So could you give us some language around?
Well, so that question is slightly different, right? So your question is a little bit about when do we need to be providing an interpreter, right? Which is not quite the same as when is it okay for an accompanying adult to interpret, right? So your question is answered by we should be providing or offering, I correct myself, we should be offering an interpreter to anyone who speaks English less than very well. But really, we should only be providing that interpreter anytime the patient or person accompanying the patient would prefer to use a language other than English. So the situation you described, Steph, the parent very clearly says, I would prefer to have this conversation in English. So do we need to provide an interpreter? We do not. And attempting to do so can be detrimental to your relationship and perceived as insulting or discriminatory. I spent 45 minutes on the phone with a father who had that experience a month or two ago, where he felt the staff really wanted him to use an interpreter, but he was talking to them in English perfectly fine, and he wanted to keep speaking in English. His particular situation, there was a misunderstanding. The staff felt that someone else who was with him was part of the conversation, and he felt they weren't, and they were just staying in the waiting room, and all sorts of details. But you can see how that impression could be given in your situation too, where this person says they want to speak English. I say, okay, and we try, but it's not working. How can we address that? Can we just say your English is bad, you need an interpreter? Is that going to achieve the results you want? It's not. We're not really able to force an interpreter into the interaction. And even if we could, it's not going to be very effective. You can't change what language someone else speaks. They control what comes out of their mouth. There's not very much you can do there. So you need to take a collaborative approach to that problem that you're describing, Steph, of saying, hey, I'm having trouble understanding everything that you're saying. And it's really important to me that I'm able to understand everything you said. Would you be willing to repeat what you just said through an interpreter to make sure I'm understanding it all? In general, I think that's better received than the reverse, where you say, you're not understanding my English, let me say it at you in Japanese instead. Like that doesn't usually help.
I have a
Well,
question.
yeah, go ahead.
Yeah,
What about using the Google language tool where you can interpret where, you know, whatever language it is, it interprets what you're trying to say. If you're sitting there, if it's going to take forever for an interpreter, is that a good tool to maybe use?
very good question. What do you guys think?
No.
So wait, what was that, Griffin?
I was being sarcastic, sorry.
No, it's okay. I think there's a kernel of truth in your sarcasm.
It's not accurate.
So the concern there is accuracy, right? So if you say that we're working somewhere that doesn't accept federal funding and we just want to make sure that we can do our job effectively, our concern is accuracy. Will it be accurate enough? A 2014 study in the British Medical Journal found that it was 67% accurate on average. Is that high enough? Probably not. The recommendation was no. However, Google Translate continues to get better, especially in common language combinations like English and Spanish. So much so that a paper was published recommending the use of Google Translate in emergency departments just in the past year. It was immediately followed by many papers explaining why that's a bad idea, because it is not as accurate as you think and can lead to a lot of risk. What's more important, though, for us at Cincinnati Children's and any organization that accepts federal funding is we don't have that choice. It is explicitly called out in the guidance as not a qualified interpreter or qualified translator. And interestingly enough, this applies to everything we do. This isn't just healthcare conversations. If I want to talk to you about where you're supposed to park, how to get to the clinic, free popcorn in the Family Resource Center, I can't use Google Translate. It does not matter what the nature of the communication with patients, families, or the public is. We have to use a qualified interpreter or a qualified translator or qualified bilingual staff. And that can't be a computer program today. To add a little wrinkle, the Biden administration's proposed change to this rule addresses it a little more explicitly and says that you could use it if accuracy was not important. I don't know where accuracy is not important in the work that we do. I'm not quite sure what that's going to mean. But the way that process works, they publish a rule, they get feedback, and then they make a final rule. So it's possible that will change before it goes into effect in the next 6 to 12 months. But that could be very interesting because I think your point, Leah, is very well taken that I'm not saying I want to do this because I don't want to follow the law. And you didn't say you wanted to do it because it was cheaper. You said you wanted to do it because it was faster, right? And on that page, I was showing you about when do we use an interpreter? We need to make sure that people know that interpreters are provided at no cost and in a timely manner. That's required by the law. We need to be able to do this, to provide interpreters at no cost to patients and families and in a timely manner. That is going to depend. Those less common languages, when someone comes into the emergency department, there's very little an organization can do. But if we're asking for a Spanish interpreter, we should be able to get there really quickly. While we're talking about this, oh, go ahead.
I know at Mercy Fairfield,
Mhm.
I happened to be in the emergency room because I hurt my ankle and I hurt my back, hence why I'm in the rehab. But they had a Spanish interpreter, but she wasn't there in person. She was there by video.
Mhm.
And it seemed to me like when she was trying to register, it was a lot of say that again, because they couldn't understand. So I'm just wondering, I guess, why they're still kind of doing that practice, because it really didn't seem like it was working very well. Because sometimes she was speaking and you couldn't hear the interpreter, or there's a lot of repeats and they're trying, and then the doctors don't understand what's going on. So I was just wondering why they thought that that was effective.
It's a good question. I'm sure that wasn't their desired outcome of having an interpreter on video. Has anybody ever had that experience on a video or phone call, even just in English, where you're having trouble understanding? That's bound to happen. Why would an organization use phone or video interpreters instead of just using in-person interpreters all the time? Yeah.
Well, I imagine if you're in the emergency department, maybe it was like late at night, like you're not gonna have people working 24/7 to interpret. So it's like these organizations, they do have people scheduled to interpret at certain times. So it's like a better logistical system.
So there's logistics, right? 24/7. Amy?
And so the other thing is availability of interpreters for certain languages, because if it's a less common language, we might not have someone in our immediate region, but it allows for people like farther away.
Yeah, so the other piece is that even if I'm cool, I like this is important, I'll pay for somebody 24/7. What languages does that person have to speak? How many places do they have to be at one single time, right? You know, we see, I don't know, 50, 60 languages each year at Cincinnati Children's. There's not a single person who can speak all those languages. And even in the ED, you have multiple patients at the same time that speak more than one language. So it's very, very tricky to provide an in-person interpreter for every interaction in a health system. It's hard for every scheduled interaction, let alone for every unscheduled interaction that occurs in the inpatient or ED or unexpected surgery. All sorts of things happen. And so we need resources like phone or video interpreters where someone's available on demand so that you can meet those needs at all, because there's not really an alternative with an in-person interpreter. The demographics of the area you're in also play a difference, which I think you were pointing to as well, Amy. You know, when I talk to people in Philadelphia, they can get an interpreter for most languages, whatever time they want, with very little notice. That is not the case in Cincinnati. You know, we have a large Uzbek speaking population. There is one Uzbek interpreter in Cincinnati that we know of. That is not nearly enough because of how many, appointments will overlap and all those sorts of things, not to mention the needs of other health systems in the area. I mean, there's probably enough work for a full-time Uzbek interpreter at Cincinnati Children's, maybe trying to work on that. And also at TriHealth at Bethesda North. They also have a large Uzbek population that goes there. But the need across the country is low. So we're stuck with phone interpreting and kind of long wait times. It's not great, but it does allow us to provide a professional interpreter. And as we saw before, that's better than your high school Uzbek or a friend or family member who's not trained as an interpreter. So stepping backwards, your question, Steph. Does this make sense as to when we should be providing the interpreter? Yeah. So there is a handy.
Because I was more worried about the relationship, but it does feel uncomfortable as a provider.
Yeah, and I think the answer is to lean into that discomfort instead of ignoring it. Like, nobody wants to talk to their doctor and have the doctor not understand them. But I think it's worse if the doctor doesn't understand you and doesn't tell you. So if you take a moment to address the communication needs, you're more likely to build that trusting relationship. And you can offer things like, can we have the interpreter here just in case there's a sentence that I don't understand? Or could you repeat that for the interpreter to say, and then we can switch back to English and see if everything else goes smoothly. Because it does matter that we communicate effectively. There is a handy flow chart that says, if people speak English very well, they don't need an interpreter. If they speak English not at all, they need an interpreter. And anywhere in the middle, it's kind of their preference. And then as far as this question of the ad hoc interpreters, we were talking about what happens if this, they want Uncle Joe to be their interpreter, but I don't want Uncle Joe to be their interpreter. How do I address this? We have to use that same collaborative approach. And here, what you can point out is that you want Uncle Joe or whoever it is to be able to support them in the encounter and help us identify miscommunication, times we're not understanding each other. And they can do that better if they're not in charge of repeating every single word, right? I can't tell you how many times I get reports where someone was at the encounter and was bilingual and said, this interpreter is doing a bad job. You should hang up and get another interpreter. They get another interpreter and that other interpreter is much better. That happens. And that's a success for that bilingual individual supporting that person at that encounter. So that's different than them interpreting every single word. So I think that would be our ask, is that you ask, hey, could we get a professional interpreter and you can let us know if there's any miscommunication. And that way you can ask questions, take notes, and do whatever it is you came to do to help them. At the same time, before your question, I think we need to recognize why people with limited English proficiency or who are deaf or hard of hearing ask their friend or family member to interpret or use Google Translate to communicate with you. Why is that so common? Yeah.
I think it's unfortunately common practice that they have to rely on family members to do that in other places that aren't receiving federal funds. And so they have now just, it's kind of a habit to them where they feel more comfortable and that's just what they're used to.
Yeah, it's a way to get by in an English speaking world. Are they going to give you an interpreter at Kroger or at the bank? Probably not. And so there's so many situations that people encounter that this is the tools they've found that work. And because we're going to provide a professional interpreter, I do think that's the right choice. I do think it will be better, but I don't think we can expect everyone who comes through our door to know that. To know that it would be better, to know that we provide it at no cost, to know that we provide it in a timely manner and it doesn't delay their care.
Could it also be like a trust factor? If you like, it's their own friend, family member, and you can trust them what they're saying back to them.
It can be a trust factor. That is a thing that people do bring up. And it happens more often when someone speaks a less common language or a language that has a lot of variety within it. And they say, look, I've tried your professional interpreters and it doesn't work. I don't understand them. I need my friend here to help me. That's a lot more common. I think most of the time for a language like Spanish, for someone who speaks Spanish as their first language, they generally have a better time with the professional interpreter than with their friend or family member interpreting. Because of things like we saw in the video, that friends aren't trained as interpreters and they'll omit things. But thank you for bringing it up. That is a really important consideration. Did you have a question, Steph?
So I had a comment about, sometimes I feel like in our specific subspecialty, even professional or medically trained interpreters do not necessarily have as much experience with the words like autism and developmental disabilities. And some of those don't always translate as, I don't know what word, but they don't always. So when I was in Nicaragua, it was very clear. I was with a Spanish speaking trainee who was like, this medical interpreter is medically trained, but not trained in our area. And so I think that is something to consider when you are potentially working with an interpreter through the phone and you're talking about behavioral terms or you're talking about OT terms. It may be a matter of just like, I think we're going to hang up and we're going to try someone new. And that's okay to do you as the professional too, because you want to make sure that you're giving the care, the best possible care you can. And that could just mean getting the next interpreter that's on the line.
Yeah, for more common languages, feel free to do that if things are not working well for whatever reason. People like me who run this service would love to know when that happens so we can provide that feedback, but I know you guys are busy. So if there's a problem and you want that feedback to go to that interpreter or their manager, please tell me. By all means, I would love to do that. But in the moment, know that you could always hang up on that Spanish interpreter and get someone else. You can say, thank you, interpreter, that's all, and hang up. You can also just hit the hang up button. They will report that as an unexpected disconnection, but whatever, like you can totally do that. It's fine. It's trickier when they're in the room. Much trickier, but can be done. You can say, interpreter, I don't think this is working very well. I'm going to switch to using a phone or video interpreter. That is okay. In fact, I had a sign language interpreter, a blue badge, works here full time, who was asked to leave an encounter because the mother thought the child was uncomfortable with his presence and would have been happier with an interpreter on video. So this is okay, but it is awkward. But again, I think it's better to address that issue than to ignore it because it's uncomfortable.
I will say I'm amused with what you said about just cut the call off, because sometimes when I've contacted a family, for whatever reason, somewhere in the call will get dropped. So hopefully the interpreter, I've never had a situation where I wanted to bail out on the interpreter. So hopefully they're not thinking what you're saying, conveying.
Probably not. I think they would expect it to be a technical issue. You know, drop calls do happen. But if they were struggling, they may think that that's possibly what was going on.
Yeah, you just start now, and at the beginning, I'll just say, infant Bert, if for some reason the call drops, I will call you back. You know?
Oh, awesome. So back to this question about non-qualified interpreters, I do want to make sure I mention that we cannot rely on minor children except in that emergency exception. That's the only time when there's no other interpreter available. So that means that your 17-year-old cannot facilitate communication for you at registration. I'm sorry, that's not allowed by federal law. We need to get an interpreter instead. We said no Google Translate. If that's all right with you, I do want to watch one more video, which is that same interaction we saw, but with a professional interpreter this time, so we can see how maybe it could have been different. Does that sound all right? All right.
Ms. Rodriguez, I understand that your religious beliefs prevent you from receiving a blood transfusion.
Señora Rodríguez, yo entiendo que sus creencias religiosas no permiten que usted reciba una transfusión de sangre.
But I want you to understand that this is a very big surgery.
Pero la cirugía que le van a hacer hoy es una cirugía muy grande.
And there's a significant chance for a lot of blood loss during this operation.
Hay una gran posibilidad de que usted pierda mucha sangre durante esta operación.
And if you don't consent to a blood transfusion, I'm afraid that it could result in your death.
Yo me temo que si usted no acepta una transfusión de sangre, esto podría resultar en su fallecimiento.
No, yo no voy a aceptar una transfusión de sangre. Eso va en contra de mis creencias.
I'm not willing to accept the blood transfusion. That's against my beliefs.
Well, maybe we could try something else. If you have significant blood loss during the operation, we could try blood products like albumin or platelets. Would you be open to that?
Bueno, podemos intentar esto. Si usted tiene una pérdida de sangre importante, podríamos intentar darle productos de sangre como albumina o plaquetas.
No, nada de eso. Nada de eso. Eso va en contra de mis creencias. Nada.
Nothing like that. That's against my beliefs. Nothing.
No te puedes dejar así. Por favor, acepta esto. Si no por ti, por tus hijos.
No. Va en contra de nuestras creencias y va en contra de la palabra de Dios. Nada. No.
Companion is saying, please accept this, if not for yourself, for your children. Patient is saying, no, I cannot accept this. It's against our beliefs and against God's word. So no, nothing.
So what was different that time?
The patient's care or the patient's wishes were abided by.
The patient's wishes were abided by. They were made very clear to the provider. Mm-hmm. What else? Yeah, she got all the information.
The provider was also given all the information.
And the provider got everything from the patient. What else?
Translated not only the patient, but the companion.
Yeah, everything was interpreted. And so the companion's voice was also heard, right? That was totally missing from the last one. So when you work with professional interpreters, you're going to have people who are trained in medical terminology, though there are always new terms and specialties that people are unfamiliar with. They'll follow uniform codes of ethics and standards of practice. They'll respect patient confidentiality. They'll repeat everything that is said. So if you don't want something to be interpreted, don't say it. Like, you can't turn the interpreter off. There's no off switch. Do not summarize, do not paraphrase, do not add or omit or change the meaning of words, right? So all of that communication is clear. Obviously, this isn't ideal. There are going to be problems. When there are, please report them to the person who's managing language access for your organization. They do want to address those. But interpreters are trained professionals and do their best to follow standards like these. When we talk about people who are deaf, there are a couple of things I want to call out. There's a wide variety of needs within the deaf community, different sign languages, people who are deafblind or have low vision. And federal law requires us to give primary consideration to the choice of aid or service requested by the person who has a communication disability. What that means in most common terms is providing an in-person interpreter instead of video when video is not effective for that person. Many people who are deaf struggle to communicate through video interpreters. Not all, but many. And so it's pretty common for people to say this video thing is not effective for me. And our bar for providing an in-person interpreter here is higher than it is for spoken languages. Any questions about that?
I had a question about,
Yeah.
in like emergency situations, can you use like a tablet or like written word? And would that go against like federal law?
So what this requires is, if we step back to that really high level, we got to be taking reasonable steps to provide meaningful access. And when we look at this particular piece, there's an understanding that it can take time to provide the requested aid or service. And so the way a court would look at you not providing an in-person interpreter for a scheduled appointment when they told you they needed one 6 months ago is very different than when they show up to your ED unexpected and say, I need an in-person interpreter right now. And I think that not just legally, but in reality, the deaf individual would feel different too. They would know that you didn't know they were coming in, and it takes time for that interpreter to put their clothes on and drive in at 2 a.m. Like, they understand that there's going to be some delay there and are much more likely to be offering you another way to communicate so that they can say, hey, here's my problem. I need an in-person interpreter. Until then, let's use video. Or until then, let's write back and forth. Or until then, my husband will interpret for me, or whatever the case may be. Great question. I was going to add, I forgot I put an extra note on this slide. ASL interpretation occurs simultaneously, so you don't need to pause like you do in spoken language interpretation, because that pausing can actually make things worse instead of better. I promise you we'd talk about Cincinnati Children, so I want to jump ahead and take a quick look at that. We offer all the different interpreting platforms here. We have these nifty new video carts that we deployed during the pandemic, and they're all over the place. And we try to send in-person interpreters all the time, but we really prioritize things like rounds, care conference, end of life, conflict or group therapy, times where a remote interpreter cannot hear or be heard. So they can't do their job well. As far as how to get a hold of us, you have a blue badge backer. It's green on one side, and I think it's like a more of a turquoise teal blue on the other side now, but it says the same thing. If you need an interpreter today, you got to call our team. If it's after hours, you call the command center or operations coordinators. For future appointments, everything's scheduled in Epic. You don't have to do anything. We'll take care of that. But if it's not scheduled in Epic, you'll need to submit a request form on Centerlink. And if you need an interpreter now, you should just use the phone or a video device, and the phone number is on there. So it's 3TALK, or if you're calling from your cell phone, it's 513-803-TALK, which is 8255. So feel free to call from your cell phone and put it on speakerphone, from a regular old phone and pass the handset back and forth. All of that works. It doesn't matter what number you call from. The only question they'll ask you when you call is what department are you calling from? But that works for us. What about for families? What if you want a family to call you? Can you give them the 3Talk phone number?
There are special phone lines.
There are lines, plural. So we made some special lines because 3Talk is like, what language do you need? And then there's an interpreter and that's it. And it's not really going to help a family because it's just an interpreter on the line. So we made these language specific direct access lines that connect to an interpreter first and then the operator. The annoying part is that you need a different one for every language, right? Because you call the Spanish one and it says, gracias por llamar a Cincinnati Children's, blah, blah, blah. You call the Chinese one, and it's like, xixini, da hao, xixinati, et cetera. So you have to look up the number every time, but they're on Centerlink and they're on the public website. If you Google Cincinnati Children's languages, you'll find the list right away. You may have to switch platforms from phone to video to in-person. It's not a big deal. And we do offer written translation as well, things like consent forms, discharge instructions, patient education materials. There's a form on Centerlink. We'll pay for it almost all the time. If we ever won't, I'll let you know. You're not going to get a surprise charge, but most of the time we can cover the cost. And if any of you speak languages other than English and want to use them with patients, families, or the public, you must be qualified. You can't just use your skills. So look for QBS or qualified bilingual staff on Centerlink. Basically, it's a short over the phone test and then you're qualified to do it. Note that that is only for direct verbal or sign language communication. We do not qualify people for written translation or interpreting or writing in the other language. So just that direct verbal stuff. If you really do need interpreting or translation or writing, let me know and we'll figure out what we can do. And I think that's all the super important stuff. Check out Centerlink about how to get a hold of us. We have all sorts of interesting information there. Complaint forms, praise forms, stuff like that. What was your question?
So I have the badge.
Yeah.
Can I write my ABS, part of my ABS in Spanish?
Nope. You are only qualified for direct verbal communication. You are not qualified for writing in Spanish or translating.
Good
Yeah.
question, Maria. What about if you have an in-person interpreter? Can they write in your ABS?
In-person interpreters can provide short written translation for discharge instructions.
Awesome.
And we can talk more about how to solve the challenges in your particular area if you want. But
Right, they're only speaking Spanish and we spoke Spanish the entire time, then I'm gonna want to write my recommendations in Spanish because that's easier for them, right? And I'll go over, oh, this is, I recommended to continue this IEP, to go to this appointment. So if I write them in English, it's gonna be kind of confusing if they, like.
that's correct. So there are two problems. So the first one is the legal piece. So if you're going to write in Spanish, I need to assess or at least document your written language skills, which wasn't done as part of your qualified bilingual staff assessment, right? So that's certainly something I could do for anyone who needed to write. So that's a barrier today that prevents you from doing it, but I could spend $100 and you could take half an hour and we could solve that problem, right? But the other piece of the puzzle is that HIM, Health Information Management, who owns the medical records, requires that anything that's in a non-English language have a corresponding English translation in the chart, which makes sense. If you write your whole AVS in Spanish, what happens when your colleague wants to see what information was given to the family? They can't read it. So now you have to translate what you wrote into English. So instead of assessing your Spanish writing skills, I have to assess your Spanish translation skills, right? Because that's what you actually need to do now if we want to use it in the AVS. And in addition to that, you have to take the time to do that. And taking the time to translate accurately is time consuming. That's not built into your role as a provider to also take time to translate everything that you write to the family. So today, what we ask is that you write that information in English and ask us to translate it. And then we can provide you with that translation that you can then give to the family. It's not awesome because you don't have it at that very moment. And I'm happy to meet with you and talk about other ideas and ways we can try to solve that problem. because we need to meet the legal requirements and the policy requirements in a way that works well for the family and you and the rest of your team.
And I think that that's where I think a lot of our standardizational practices could be translated into Spanish, and at least we have those as smart phrases.
Yes.
So that can definitely be done.
That's been done. We piloted that on hospital medicine with discharge instructions for common diagnoses and like a 2-column layout. And they found that that helped a lot because they see a lot of patients for the same thing and they can be really standardized. There are other areas of the hospital where things aren't that standard. I can't just have it be exactly the same. What I think should exist is a big database of things that are pre-populated you can kind of put in, right? There's a company that had that vision, pitched it to Epic, and Epic said no, they wouldn't let them integrate that solution. So I'm not aware of an option today inside Epic that can allow us to do that easily and at a super large scale. But maybe there's ways it could work in your area.
Yeah, because like, for example, for all, well, some of my patients with ASD, the diagnosis of autism, I'm gonna want to recommend ABA, and that's something standard, like I could give the recommendations like in a standard way, right?
Yep.
And that would be super easy to just have it in Spanish.
Yep, exactly. And what we do is we have it in a 2-column layout with Spanish and English. So you insert that smart phrase and it comes in as 2 columns. And so everyone can see, yes, it says it in Spanish here for the family, and here's the corresponding English right next to it. That works pretty well in inpatient areas. You know, you have to make some modifications and some changes, but we have found ways to make stuff like that work.
I have a quick question.
Yeah.
If we are, say we're in a situation where the patient has some type of disability and they're over the age of 18 and the parent has guardianship and the parent at that time is doing the interpretation. So let's say that the patient doesn't agree whatever the treatment is and doesn't want to do it. Will the parents trump what the patient wants because of guardianship?
So what's tricky here is the combination of those issues, I think, right? So for the parent to be interpreting, it would have to have been the child or the individual with limited English proficiency who asked them to interpret. But it's a little ambiguous when we look at the legal requirements here, right? My 5-year-old son doesn't get to choose what language he's going to communicate in when he comes to the doctor, right? I would have that be able to make that choice of, you know, do we need an interpreter or not, or should I be his interpreter? So I think it gets a little bit messy and tricky there. What I would say is that reliance on that adult is not appropriate when you have concerns like that, right? If you think mom thinks one thing, child thinks another, mom should not be the communication channel for the child. That conflict of interest, like we saw in the video, is not going to end well. Probably not for anybody in that interaction. So I think if you have that concern, I would say that it's not appropriate to be relying on her to facilitate communication. Now, who gets to make the final decision as far as treatment? Well, that's just regular guardianship, and you can set aside the language piece of it. What else? What other questions or concerns do you guys have? Yeah.
Is it still the same guideline that you cannot get outside information translated? You only translate children's documents, is that correct?
So we can only translate things that we are legally permitted to translate. And so what's tricky here is the copyright laws govern written translation. So if Cincinnati Children's made a document, well, we own the copyright. We can do whatever we want. We can translate it, it's fine. But if someone else created the document, we need their permission to translate it. And that's not a Cincinnati Children's policy. That's not a healthcare law. That's copyright law that's governing that. Now, most of the time, people are happy for us to translate things. You know, the American Heart Association has a document that we want in Arabic. Cool. They will say, sure, translate it and give it to us in Arabic. It costs them nothing and they have it in Arabic now. So many times organizations in healthcare are very open and willing to do that. But if you can't get a hold of them, or if they say no, there's not much we can do there. Now, Kristen and her team, if it's patient education, can probably help you create something similar that could achieve your goal and be a Cincinnati Children's document. Yeah.
I worked one weekend and I wasn't really sure what to do, so I just was like, I'm gonna do my best. But my patient that needed to evaluate, we were using the mobile translator. Where do you put that? Like, do I put it next to me? Like somewhere in between us? I mean, obviously they need to be like here, both of us. I just wasn't sure, so like, I'm just gonna put this thing next to me because I asked the nurse was like, I've never used one before. And I was like, well, I have to do this, so I'm just gonna try and figure it out, but.
It's tricky. There's not a best answer that works all the time. You identified the biggest concern, which is that everybody can hear. As everybody can hear, you've met the minimum requirement. So then the next question is, who should the interpreter be able to see? If you're demonstrating how to do something with your hands and your body or a model or a picture, the interpreter should be able to see you. If you're sitting right next to the family, maybe the interpreter can see both of you. That's cool. But I think if there's not one of those situations, I'd position the interpreter to see the person with limited English proficiency. Mostly because there's going to be a really strong temptation to look at it. And you are trained and you can resist that temptation and make eye contact with the family. The family is not. So I think making it easier for the family is probably what I would focus on. I know we're a little bit over time. Any last questions? Yeah.
For example, a family came and they have like an ad hoc translator, and they're like, even though they are not doing good, but families still insist on like having them, and they're not okay with the professional, then what should like the approach should be from the provider?
So we need to talk about it. If the ad hoc interpreter is not doing a good job, relying on them is not appropriate. And so you need to find a way to bring in that professional interpreter. I don't think saying I have to do this or it's the law or it's required really helps you. I think saying not everything is being interpreted, and we need to make sure that I understand everything that you're saying and that you can hear everything that I'm saying. So we're going to switch to a professional interpreter, and I want you, this person who was helping, to stay and let us know if there's any mistakes or confusion. So instead of interpreting everything, you can focus on the problems for us, because I think your skills are really valuable on making sure that we communicate clearly here. And so you can focus on the problems as opposed to focusing on interpreting every single word. I would also say if you're super stuck, call me, right? If it's here or wherever it is and you can reach out to that person and it's a tricky situation, I would be more than happy to help. I don't want you guys to feel like you have to deal with all these challenges alone. This is tricky and difficult, and you might not know what resources are all available. So please call if there's any sort of issues or you need any help. Thank you guys for your time. I really appreciate it. Yeah, absolutely.
Awesome. I'm gonna slide in here and end this show. If you just need, I know we're running on, running a little behind. So if you just need to get up, move, shake around, do that. And then we're going to try to get quickly into health literacy. Get them out of the way. Move me in here. Get some email. No, I do not want to stay signed in, and it's going to make me go back to Andy. I want to go to this one. It never fails, and it always takes you back to the last person, even if you click those buttons. No, I don't want to have Andy.
And if we get to tomorrow and it's like 6
View accounts, sign out. How do I sign him out?
Yeah, I mean,
He did this. Switch organization, sign out. There we go. Woo. All right, try it again.
Qualifying you for translation is gonna be harder.
Best life name. Shoo. Did it again.
Not allowing.
Sign into me. Sign in Stephanie Weber. This one's not gonna work again. Oh, I don't want Andy. Come on. Sign out. And then I log out and then I log back in and get rid of all of that and it still doesn't like me. Microsoft 365. Come on, buddy. Oh, I'm hopeful too. Come on, come on. Come on. Andy Schweiter. No.
No. What resources do I get to the family?
And Stephanie Weber.
Tell them, hey, call this number and get an appointment. They call.
Sign in with a different account. Let's see if this will work. It's the only thing I didn't try yet. No. Well, it's not, it's like, it won't let us into yours and it won't let us into mine. Andy, it won't sign you out. No, to get to my Microsoft, to get Kristen's slides.
I think it only.
You did. And then just re-sign it again, yeah. Even though I'm there, that's probably part of it. Work. I blame Jane, who was here earlier, because it never fails.
Okay, maybe wait a minute. Okay.
Yeah.
I was gonna say, wait until it closes all the way out.
And maybe I just do it from here instead, even though I don't like, I don't like Bing or, yeah, but maybe this will be better. Watch, it'll sign in Andy. Oh, yay! Now my problem is my fingers don't always work well, but I did. Yay!
Yay!
Okay, Outlook. And
One of these days,
you know,
I'm gonna be
it was.
here and I'm just gonna be in person.
No,
We're not gonna have
I
masks,
know.
and we're gonna have
everything
here, and-
working. It was just, it's one of those days where like I ran down here and didn't have enough time to pull these up before we even started the 1 o'clock session. So it was like, you know what? It happens. And if you go over a little past, I'm good. They're
There's a talk fast, but there's getting interactive, so
yes,
that's
yeah, they're getting more interactive as we go along. This is week
Yeah.
5.
okay.
So they're starting to get pretty comfortable with them, so, like with each other and everything. So that's great. Oh, green. Oh, nope, that was his. You guys both have pink.
I know.
So that's why I got confused. Okay. It's over here.
Sorry, I was.
Do you have videos or anything?
I do.
Okay, and are they built in?
Yes.
Okay.
I think so.
Wonderful, great. All right, so then what we're gonna do is we're gonna get rid of my email so it doesn't bang as we go through, because that gets annoying. And then we're gonna do. There it is. Nope. Any Griffin. Where do I find? Where's our tools? So I can share screen. Okay. Zoom? Nope. Bear with us, Walia. Where did they go? This one?
Is it over here hiding somewhere, I wonder? Where, see, I always default to singing EIBI songs. It's not kindergarten preschool songs.
trying to remember.
I'm working on it. Or even on Thursday.
Huh? Like this?
Like, come more here.
Meetings? We're in progress. This is real big struggle right now. Nope. I didn't want to do that either.
I'm trying to remember what the shortcut was to it.
None of that is coming up, right? Display settings? Yeah. Ugh, how did you get that? Control H? Control Alt.
Shift H.
Why H?
Hide and unhide.
Oh, man, thank you. All right, sorry, Brandy and Walea, we are, and I think Greg's out there, but he's being hidden right now from us. We're having a little trouble finding what we needed to find here. Let's see. All right. Now, well, of course. Show video panel. Hide floating. Now, if we move these three folks over here, you'll be able to see them and your slides. And then we click on this and it lets you use this. Okay. Yes. Okay. Woo. Thank you for bearing with us today, all. It is a, thank you, Andy. It is a Monday, Tuesday, but feels like a Monday. That's for sure, right? So we have Dr. Kristen Laswell, who's going to talk about health literacy, and I will not take up any more time.
Thanks. Well, all of what Andy had to say was important, so I will be quick and speedy. So I am a nurse by trade. I work in the Center for Professional Excellence. My role is patient family education, and I also do our clinical advancement program. So today we're going to talk about health literacy. So kind of compiles on what Andy talked about a little bit with interpreting and language access services. So we have objectives, talking about health literacy and health outcomes, barriers for patients and families with low health literacy, and some strategies to improve communication. So the main definition of health literacy is the ability to read, understand, and act on healthcare information. It's a little bit different from just plain literacy. Literacy, if you can read it, great. That's kind of what they consider literacy. With our patients and families who come to the hospital, we want them to be able to understand and know what to do next, right? If they read it, fantastic. If they don't understand what to do when we send them home, it's a problem, right? That's why this is so important. So Healthy People 2030, hopefully you guys have all heard of that, the nation's kind of overall goals for the country for health. One of their overall goals is to eliminate health disparities, achieve health equity, and attain health literacy. So it's not something that we're working on here only at Cincinnati Children's. It's something that's kind of countrywide, like kind of infiltrates everything, right? So it's not just something that Kristen's assigned to, and this is what we do because we're at Cincinnati Children's. It's something that we do because it's the right thing to do for our patients and families. So looking at readability and just plain reading statistics. So we're not looking at health stuff at all. Looking at Ohio and Indiana, this talks about the percentage of a population of each state that reads below a 5th grade level. So if you think about a 5th grade level, that's maybe the back of a box of cake mix, right? And be able to follow those basic instructions. So Ohio, Indiana, kind of our tri-state area, we're at 15 to 20%. But do we get patients just from Ohio, Indiana, and Kentucky? No. So there are some states that are 30% or greater, right? So all of these patients and families, and you think about this and you think about literacy, and when patients and families come here, they're in a huge crisis, right? They're in a stressful time. They don't know what's going on. They're kind of coming to our culture, so to speak, where we're like, we know what we do. We're all involved together. We know each other. And they're coming into that world. And so that kind of tanks any kind of literacy they have, right? Because we're talking to them in new terms, explaining new things, like going to different buildings, like all of those kind of things. So that makes this even worse. So looking at Southwestern Ohio health literacy, see if I can move this over just a little bit more here so I can see it better. Adults with below basic literacy skills can only locate information in a simple text. So if you give them an appointment slide, they may be able to see and read when the time of the next clinic appointment is, but they may not be able to go through more complex documents, maybe your ABS, right? Depending on what kind of instructions they have there. So basic literacy skills, health literacy skills are, you can locate multiple pieces of information on a document, but you may have trouble figuring out what this means or applying it. So if we say your body mass index is in a healthy range, what does that mean to them? They may be able to identify that, but again, what does that mean in terms of acting, right? So those things all kind of go together. Talking about intermediate health literacy skills, they have more skills and they can understand and apply medical information, but they may have trouble going through different contexts. So some consent forms, those are difficult. Health insurance forms, some of those that we have to fill out, or drawing inferences from health materials. So if you think about patients and families, and us too, when you get a diagnosis or something comes up or your doctor says, hey, you have sleep apnea, what do? Get out your phone, Google it, right? So I'm not gonna lie, I do the same thing. But they can't draw inferences from those healthcare materials. So if they go to WebMD or Wikipedia and they say sleep apnea is gonna kill you, they may not know that that's not true, right? They may not know that maybe that's something that they saw that maybe they should bring back to their doctor. So they can't make those inferences. Proficient healthcare or health literacy, they can use a table to talk about insurance costs, that kind of thing. Who do you think proficient health literacy adults are? Correct. So we are those that are health literate proficient, right? So if you think about, usually I think I've seen statistics that it's like 13%. So if you think 13% of us are in the medical field and we understand some of those things, that leaves a lot of people that don't understand what we're talking about, right? So that's why it's important to kind of think about that. And this is a national survey that's kind of categorized this. So it's not just, again, Kristen's measure of health literacy. So I am going to skip by this today. Number one, I don't want to mess up our technology, but this will be in your slides. You can go to it and it kind of drills down a little bit more. It's from UNC Chapel Hill, and it drills down what the levels are of literacy from below basic to basic, intermediate, all of that in any particular area. So you can go to Hamilton County, you can go to Butler County, you can go to kind of surrounding counties here or maybe where you live and kind of see what your rates are. It just kind of drills it down a little bit more. And this works.
Yeah, gotta scroll over there.
So over to this one. Okay, thank you. There we go.
You know, some people like sorbitol flavoring additives, but I'm a traditionalist. Anything with a phenolic aldehyde base goes great with any of the garnishes. Now, we have several variety of aggregate fruits and vaccinium, as well as some triturated fermented cacao bars, plus some great gum arabic-based confectionaries. Now, some are made with fumaric acid, but that's just too sour for me. I'm sorry. Sometimes I can get ahead of myself. I should have asked if you'd like an independently standing flat bottom cornet or an articulated wafer cone.
At Lilly, we want to help people make confident, informed decisions about their health. That's why we're so committed to clear communication. It takes a lot of work to make things easy to understand, but it's part of our promise to make life better for people around the world.
Now, would you like to top that off with some extruded cornstarch emulsifier.
So any thoughts on that? Did you understand what he was asking? Even with, I love that guy, and I use that as an illustration because it's something as benign as ice cream, right? You're going to an ice cream, you see all these visuals, he's showing you things, he has all the energy in the world. I love to have him, taking care of me in a stressful situation. But even so, looking at her nonverbals, she has no idea what he's talking about. I don't know what he's talking about. And that's something as benign as ice cream. When families and patients come here, it's even that much more critical, right? So that kind of just illustrates why this is important. Again, I don't know what I'm supposed to do. He's asking me questions. I don't know what my action is to be able to follow that, to know what I'm supposed to do at this point, right? It's kind of a good illustration of that.
Click outside of the video on just the slide deck. And then your person.
And then I'm golden. There we go. Thank you. Things that can impact health literacy, skills. You may not know how well your family, like what kind of education they have. So they may have some skills, they may have additional children. This may be their first child. So all of those things, if you have a mom coming to the hospital for her first baby who's 6 weeks old, maybe has RSV symptoms, it's very different than someone who has their teenage child who's number 4, who's graduating from their chemotherapy and is in remission now, right? Those are very different places. Same thing with that context. We don't know where they are in their journey. Also culture. So as Andy talked about, if we're having a family that doesn't even speak our language, that adds a different problem kind of onto what we're dealing with already, right? I can't imagine going somewhere and having someone care for my child or have surgery or something like that if, number 1, you're in a hospital, number 2, you don't speak the language, right? So that kind of just adds to our problems with health literacy and why it's so important.
I was sick a lot. I was sick a lot because I probably missed dosage and didn't realize it. I was in the hospital a lot. When they did give me medicine, I didn't take it right. I admit to it. I just didn't understand them, and I didn't have the nerve to ask them the right way of doing it. I just didn't have the nerve to ask them, and I didn't want anyone to know I couldn't read.
I can't read this. Well, I guess doctor gave it to me, so it's okay for me to take it.
When your children have fever, what do you usually give them?
Motrin or Tylenol. Normally Motrin because that's what my doctor recommended.
How old is your daughter?
She is 4.
She's 4. Okay.
I would give her the 4 to 5, a tablespoon and a half.
One capsule.
That's right. One capsule.
One capsule. I don't know this is.
Twice?
Twice daily.
Okay.
Okay.
So how would you take this?
When I see it's not on there telling you how to take it. It say take it twice daily, but it don't say what time to take it.
Do you know what hypertension means, if I asked you what that was? Because when I look at this, I think, well, maybe you have hypertension and I've been taking care of that for a long time.
Hypered? Hypered?
Like you're hyper? What does being hyper mean to you?
That's where you can't be still. You always got to be doing something.
Do you think I think you're hyper and have hypertension?
I don't know. That's what I consider it.
Okay.
It being,
Okay. But you know you have high blood pressure. Okay, but hypertension doesn't mean the same to you. So if I ask you if you have hypertension, you're going to just think, I think you're jumping around on the chair or something like that, something different.
Just being hypered,
Okay. All right. Well, I haven't done a very good job teaching you what hypertension is, because I think you take that medicine for your hypertension, and that's one of the things that I try to work with you on is your blood pressure. And high blood pressure and hypertension, to us, is the same thing.
The same thing.
Yeah.
I have a small breakfast, and then I take my pills. I usually take 16 every morning. Sometimes it's difficult to for me to take these pills because of they say 1 tablet twice daily. I don't know if they're talking take 1 in the morning, 1 in the evening, or take 1 in the afternoon or 1 in the evening. So usually what I do is take 2 of them in the morning. Then this way I know I have them.
If you have a reading problem, you go to the doctor. That can be very scary. It's like a nightmare. You walk in that office, and most people, if you realize the first thing you're going to have to do if that's your first visit is fill out a form. Your heart beats real fast. You're scared. You don't know what to do. You want to turn around and walk out. I have.
At approximately 30 or 31, I went into the gynecologist and complained about part of this not working correctly. And he said, we can repair that. Great. I didn't ask all the right questions. When I showed up 2 weeks later at the admissions office at the hospital, they put enough papers in front of me. I'll bet there were 5 papers that I needed to sign. Well, I wasn't going to say, excuse me, but I don't read really well, and I certainly don't read fast, and I'm concerned with some of these words. To me, it was lines and circles over sheets and sheets and sheets. And I wasn't going to reveal my sense of stupidity, so I signed everywhere they told me to sign. Never read it. And then a couple weeks later, in the follow-up office visit, the nurse said, how are you feeling since your hysterectomy? Now, I acted as normal as I could. Inside, my mouth fell open, and I thought to myself, how could I be so stupid as to allow somebody to take part of my body, and I didn't know it?
Chair kind of groans with that. What did you guys think about that? Scary. Has anybody ever thought about that before? Or been in a situation like that, that maybe you're like, I don't even know what's going on here? So I do share this a lot with, I speak to a lot of different groups and new nurses and that kind of thing. There's a lot of things that get me about this video, and if anybody has anything they'd like to say, please chime in. Number one, we label a lot of these patients as non-compliant because they're not taking their medicines as prescribed. They're not, that woman who takes 16 pills in the morning to get them in, she is doing her darndest to follow those instructions and to act, as we said, right, on what we're expecting her to do. My fear with her is, what if it's a heart med? What if it's a blood pressure med? She could end up on the floor halfway down because she's bottomed out her blood pressure from taking 2 doses at the same time. Also, some of these, the church deacon, it's a master craftsman. Those are things I can't do. I don't have those skills. If I go to those places and see them for any kind of care for anything that they do, I'm in their world and I would know nothing. So when they come to my world, I need to make them comfortable, right? It's kind of up to all of us to do that. And so that's why we try and do some things here to kind of help bridge that gap and make things understandable. That's why we're talking about this. That's why I talk about it in a lot of groups, because I have a few different nursing degrees. I've never talked about health literacy until I got to this position. That's a problem, right? That's why we need to be aware of it. Michelle.
I worry about it with my own son. So I have a 20-year-old son. We don't have guardianship, but we will sign papers for power of attorney for healthcare. But what if where he ends up at some point isn't a hospital or a nearby doctor or whatever, and he doesn't understand?
Mm-hmm.
You know, it's definitely something I've thought about before too.
Yeah, absolutely. And how do you, it's hard when they get to those adult worlds because maybe they don't think about it. You're right. Like, depending on the size of the organization, you don't know what their thoughts are in health literacy, but having that extra set of ears, if they'll let you go, you know, having a caregiver, someone else to hear what they're saying, or to say, maybe if you're not outspoken and it's a stressful situation, as being in the hospital is, you can have somebody else there who might be a little more outspoken than you and be like, hold up, we don't get that, like, back up. Because sometimes physicians and caregivers get in the position of, I'm just going to tell it again. You know, I've seen this patient, we've seen a patient in the clinic all day. I work in ENT, we see a lot of ear tubes, blah, blah, blah. But it's not the same for patient and family, right? So that's what we need to take in account and make sure they understand. Any other comments about this before I go on? Go ahead.
So I have a master's degree
Mhm.
and I still like that. It doesn't change the fact that when the first time I went to my son's 40, she said the word proprioception and I was like, what in the world is this? Because people assume that the parents are educated, they know all the terms that's out there, but there are terms that are specific or the parlance is specific to that particular discipline. And it's like you don't know, although you have the kind of education that people think would make you understand everything you're saying.
Mhm. That's a great point. I've taken care, I worked in the recovery room for years, and we would have families come in and they'd be parents or, like professionals, nurses or doctors. And we always say, you're not a doctor today, you're mom. So, and that's very different when it's your daughter or your son that's in that chair and you're trying to do your best to care for them. It's maybe not your expertise, right? So very important to remember. You need to say.
This was highlighted in training we did across the whole organization called Care Promises. We often ask people about their experience in going with others to seek healthcare. And it was very, very common for all these healthcare professionals to not tell the other people there that they were working in healthcare. Because it's not their specialty, and they don't want to be talked to like a professional. They want to be talked to like a family member. So everybody's preference there is going to be different. My mom worked in a medical lab. We could not stand when people wouldn't give her blood results. They're like, oh, your numbers are going up. And she's like, I want to see the lab report. I work in the lab. So like, it's a person by person piece. What we really need to be aware of and not over generalize what we think people understand because it's common thoughts.
Absolutely. Just something else.
All right, really quick. Nelly, can I have you run the, we're gonna need to have a microphone champion for each session or something. I was just gonna say that. Oh, I was on, I think.
Hello. Okay. No, I was just gonna say that I think about that when I work in the schools because we do a lot of reading interventions. It feels like kind of like a trickle down effect when it comes to literacy because you're doing reading interventions for these students and like the goal is for them to be proficient in reading as they become adults. And I feel like there's this situation where it kind of builds on as you get older and older and you're still not proficient in reading to the level that is expected of you as you become an adult. So I don't know. I always think about that. And like when you mentioned health literacy, I think it's so important and I would love to learn more. And I'm excited to learn more just because I think about it when I like with the students that I work with.
Right. It's in lots of different settings, right? Same thing when I go to, as I said, like a car dealership. I don't want you to talk to me in car dealership terms. I don't know what you're saying. Tell me about my engine, what needs to be fixed, how much does it cost, right? Give me the basics. So great point, you guys. All right. So other reasons why health literacy is important. Patients with low health literacy are more likely to come to the emergency room because as we saw that patient, the mom who was going to dose her child with like 4 to 5 tablespoons of ibuprofen when it was supposed to be 1.5 teaspoons. She's not trying to do anything wrong. She doesn't understand, right? They may have more hospital stays. If she continues to give her daughter that much ibuprofen over a long period of time, there's probably more lab work, fluids, all kinds of stuff that needs to happen in the hospital, right? They're less likely to follow treatment plans, not necessarily because they're being non-compliant, as we say, because they don't understand. What if they don't know how to call to schedule the follow-up appointment? Maybe they have to read a bus schedule to get there and they're unfamiliar with that. What if they don't know when to do it, right? And because of all this, they have higher mortality rates. So again, why do we care if families understand? It leads to increased medication errors. And for those of you who are parents or have young children or family members, when you can't help them and you can't manage their care and you can't help them get through a situation, you don't feel good, right? We don't want to make our patients and families not feel good, like they're not doing their job when all they're trying to do is do the best for their child, right? So how can we help this? Clear, effective, and respectful communication. When we talk to them, we want to be clear. We don't need to use all the words we learned in nursing school or when we went to school and our master's degree, clear communication, also effective. So patients and families know what to do, what their next steps are, and be respectful. These parents have been parents of this child a lot longer than I've known them. They are mom, they are dad, they have all that knowledge. So we want to include them to be part of the team. So just some quick steps that we're going to run through. So universal precautions. We all know that part of universal precautions is putting on our PPE, our gloves, our masks, our gowns, all that kind of stuff. Only 12% of US adults have the health literacy skills to absorb and use health information. And like what we talked about in that below basic, basic, all those levels of health literacy. But as Andy said, we don't know which patients and families are challenged by this event or by this information. So if I talk to Lisa here and I say the same thing that I'd say to Griffin, there may be a different level of understanding for both of them, right? They may not know, one may know what to do next, one may not. So we have to teach health literacy and plain language as an always event. Jaco talks about never events, things we never want to do. Health literacy, plain communication, clear and concise is an always event, something we always want to do. Things to know your audience. When you're talking with, I'm sure Andy can elaborate much more on this than I can, with patients maybe from other countries or other situations, or they may have different cultures and practices that they may not listen to me as well as they might listen to a man. So maybe if I have somebody in there from my team that we're working together to talk to this dad, and they're more likely to take information from a man, maybe that's something that's a little easy that we can do so they can get the information they need. Same thing about perceptions. If they're not big on Western meds, they're not big on taking meds at all, like let's incorporate them. Let's have a discussion with the family and include them in their preferences. How can we make this a better thing? Same thing with attitudes. They've had a bad experience in the past. You know, you're probably going to get a little stiff arm, like, nope, stay away. So how can we bridge that gap to make things a little bit better? And again, we talked about where are they on their journey. That mom who has a child who is just getting ready with chemo probably has a much higher health literacy knowledge, I would assume. Again, I don't want to make assumptions, than a brand new mom who comes in with a 6-week-old with RSV to the ED, right? So we want to consider those things and probably not teach them the same way as we would teach, you know, each other. You hear nothing else that I say, use plain language. So plain language is also called living room language. So think about how you would talk to your grandma, your spouse, your best friend in your living room about what you're doing today. I wouldn't say, well, I made an incision and it had serosanguinous drainage and I put a tech, like, no. I made a cut today in surgery on this patient and I put a, you know, like a piece of gauze on there. Something like that. Like all the words that we learn in our degrees and that kind of thing, they don't really matter. How would you tell them to grandma so she could understand? Also, you want to use communication that your audience can hear and understand the first time they read or hear it. We don't want to have to go through some big long explanation trying to explain what we could say in a sentence, right? We don't want to have to explain this big car. Like we could say the car has 4 doors, the car is blue. That communicates a lot more maybe than this whole long drawn out sentence, right? All right, one more video. We do have time.
Plain language. Say it simply with Sam Snoop.
I'm Sam Snoop, the plain language sleuth. And this is my sidekick, Maggie the magnifying glass. Maggie and I are working the plain language caper. Our job is to smoke out writing that's too tough to read. Then we fix it, make it simpler. What is plain language? Think about what you say when you're just yakking with your family, friends, and the gang at the office. How do you talk? Simply, right? That's because you want people to understand you. But do you write that way? Imagine 2 baseball buddies sitting at home watching the Minnesota Twins on TV. One's Peter Plainspoken, the other's Gloria Gobbledygook. Peter steps away for a minute and misses a play. When he comes back, he wants to know what happened. Wouldn't you?
So what did Mauer do? I have received your inquiry and am prepared to respond.
According to the official rules, section 423.098, subdivision 379.222, paragraph B, a run can be scored by the batter when said batter makes contact with the baseball with his bat. Several situations may then ensue, which allow the batter to touch all bases consecutively without having recorded an out. In situation 1A, the ball makes contact with the bat and is then propelled to a point where...
So he hit a home run. Is that what you're saying?
The response to the oral communication received by you and dated May 1st, 2013 has resulted in an amended affirmative response to the initial interrogatory received from the above reference.
Does that mean yes?
According to the rules, section 423.625, the correct answer...
Did you understand what Gloria was saying? Even if you did, why would you want to? Who's got the time to be a translator? It's the same thing with writing. Whether it's a letter, email, website report, anything else. Make it something your readers understand the first time they read it. That means use common terms. Keep your message clear and make it easy to understand. Only write what's needed. Be direct. Think of some of the great plain language messages of all time.
Ask not what your country can do for you. Ask what you can do for your country.
I'll be back.
Where's the beef?
Yeah, these messages stick because they're so simple. We hardly have to think at all to know what they mean. Got that? Now, check this out.
It was freed from the retrosternal aspect of my chest wall, and an endoside anastomosis to the LAD was performed. Left anterior descending artery.
What a mouthful. Unless you're a doctor, there's no way you can figure out what's going on here. Get the picture? When your readers don't understand, they get confused. It also wastes time and resources, both theirs and yours. We don't want that. That's why Maggie and I are on a plain language mission at all Minnesota state government agencies. And when you work on your next letter, fact sheet, or email, take these 5 steps. Plan, organize, write, edit, review. Plan before you write. Talk about what you're writing with communications, legal, and subject matter experts. Talk about the content's purpose. Know your reader, their situation, and how they will receive the information. Organize the information so it's easy to understand. Select the right and right amount of content. Arrange the information logically and format it for easy use. Write the way you speak. Use everyday language. Use active voice. Keep sentences short. Edit with your reader in mind. What questions will they have? What do they need to know now? Would a list or table make something easier to understand? Review what you've written. If you can, put your document down for a while and come back to it for a fresh look. Try reading it to a friend or your neighbor in the next cubicle. Test it with real users. That's the power of plain language. Say it simply.
Produced by the Minnesota Department of Revenue Communications Division, www.
Who knows somebody like Gloria Gobbledygook, who tells you everything you'd ever want to know about a subject, right? Yeah, that's kind of the opposite of what we want to be. Like, if you're going to tell me about a medicine, I don't need to know amoxicillin came from penicillin that was invented in, like, do I really need to know that? No. What I need to know and the important things are how to take it, what I need to do when I need to give it to my child, right? So just kind of another illustration. Questions or comments about that? No? Okay. I'm gonna, just because we only have a little bit of time. So something else we use is called Teach Back. So have you guys heard of that before? Let's see if you had. Fantastic. So just a reminder is using plain language, as always, start with the why. Families need to know why they're doing what they're doing. So I don't know about you. I always like to know, if you tell me I need to drink 5 gallons of water a day, why do I need to do that? If I know the why behind it, I'm more likely to follow through, right? Also, chunk and check. Give small amounts of information and then check for understanding. So if we're talking about doing a dressing change and I say, okay, you need to gather a piece of gauze, a piece of tape, and I don't know, and something to clean it with, some soap and water. And then I remind them and say, okay, so tell me what things you're going to gather to do this dressing change. And they can't tell me those things. It doesn't make any sense to go on, right? Because we haven't established step 1. and we're not there yet. So it's not a good use of my time or their time to go on because that's going to confuse the issue. Also, create a home-based scenario that'll generate key questions. As we talked about, patients and families are in this chaotic place here. We're doing a lot for them. There are lots of hands around all the time. So when they go home, it's going to be a different world. So whereas they may have had hands to help them get their child to the bathroom or something like that, that may not be the case. So where are they going to put their child when they get home from a bilateral knee surgery that they can get to the bathroom easily? Where are they going to position them so they don't have to go up steps? Those are maybe the things that they don't think about when they're kind of in the throes of this crazy place during the surgery, right? Also using what questions do you have instead of do you have any questions? Do you have any questions kind of has a feeling like, hey, I'm such a great teacher that you guys don't have any questions because I did such a great job. Whereas what questions do you have is more like, we've talked about a lot of information. I anticipate that you're going to have questions, so let's talk through them, right? It kind of establishes a little bit of a different rapport and a different kind of openness rather than just like, hey, well, do you have any questions? Nope. Okay, bye. So it just kind of promotes a little bit more congeniality. How do we use this at Cincinnati Children's? This is our patient family education page. So you'll notice here on the left, at the very top of the column, we have health topics and knowing notes. Those are our main types of patient family education. Health topics are things that live on the .org, so they're public facing. So they are things like conditions and treatments and kind of different things that we do here, whereas knowing notes are internal only. They are only available through Centerlink. They are things that are very specific to care, how to put down an NG tube, how to use a nebulizer, more information about this particular medicine. So all of those things, we probably have 3,500 to 4,000 different documents. Our digital strategy team was just telling me that our health topics see 39 million views a year. So we're getting a lot of traction on some of this stuff, and they're all written by clinicians. They're great information if you don't know that they're there. So as Andy was talking about, we want to standardize our patient family education too, so that when you come to an ENT clinic, when you come to surgery, when you come wherever in the hospital, if you get a knowing note, you know that that's a patient family education piece. So that's what the middle is, where it says knowing note templates. All that stuff is there available for you to help create a knowing note. Let's see, we'll go to this too. We also have videos as well. A lot of those are created by different teams throughout the hospital. And we also have a few approved outside education, usually things like Diastat or, some of those medication things are things we use from outside organizations. All of these things, knowing notes, health topics, videos, we have connected to MyChart Bedside. So are you guys familiar with what that is? No? Okay. MyChart Bedside is a inpatient tool right now. So as part of Epic, everybody in an inpatient room has an iPad in their room. So it's kind of a communication tool for patient family experience. It can share education. It can share like all kinds of things on it. It can share what your itinerary is when you're the patient for that day. It can share what appointments you have coming up, when your meds are due. You can order food on it. You can look at your education, all of those kind of things. Like it has a lot of great different resources. Currently, again, only for inpatient. But anything that you see on there in terms of patient family education, knowing notes, health topics, all of that are part of your MyChart account when you go home. So that's the great thing is when it's shared on there, then patients and families can look at it when they go home and say, I don't remember what the steps were to put down this NG tube. Oh, but I can go back in my MyChart and that knowing note is there for me to look. So that's a great tool. I will say there have been a few struggles with utilization on the floor. We are working on that, but those things are all in there for you. We have been working with our teams to update our education titles over the last year. So the education that we're providing is consistent with the patient populations that we're seeing on the floor. So there is a lot of work being done on the back end on that. This just shows you an example of a knowing note template. It is all ready to go for you. All the font is on there, all the different coloring, all that kind of stuff. It's approved by marketing and branding. So all you have to go in is go in and type. So once that happens, it comes back to us. We ask that you write a 7th grade reading level or below. That is our hospital policy. Sometimes we know that some of the language that we use around here, if you're getting chemotherapy, you need to know what chemotherapy is. So if there's an explanation or if there's a word that we could use and kind of use some plain language, we are glad to help you with that.
Kristen, I have a question about
Yes,
that.
ma'am.
We run into the issue where some of our branded materials actually don't align with our the disability accessibility standards, like even this document is in serif font instead of sans serif. So how do we navigate that? Just email you?
Yep.
Because we're telling these folks a couple weeks ago, like, you can't use sans serif, you can't use serif font on any of your presentations, and then, you know what I mean? Like,
right.
Or, is there something that we can do maybe to work together to include the disability piece into marketing's understanding of what we do?
We'll have an offline conversation. Yes, absolutely.
Thank you.
Yeah. So this is how this kind of ties to Andy. We work really closely with language access services. Any of those knowing notes, health topics, all of that are available for translation. If you click on those and you go to the knowing notes page, it's categorized into different categories and different services. If you click on there, if we have anything in Spanish, Arabic, somebody asked for Hebrew one today, Nepali, anything that we have is listed there for you. If you don't see it and you want it, email me. We will take care of it. We will connect with Andy and his team and we will get it done. So again, Andy talked about the copyright concerns, so I don't want to go over that again. Sometimes we get a lot of different things that are not approved patient family education. We know a lot of things are being made that are not approved and branded appropriately. If you see those things, please send them my way. We don't want to take them away. Again, we just want commonality and standardization throughout the hospital so that patients and families know what to expect when they get their patient family education. Usually the translation, they are fantastic. Andy and his team are great. They will get stuff back as soon as they can if it's a rush, if you need it for an particular patient. If you're like, I have a patient that's coming in a couple weeks, usually it's a 2-week lead time, just to make sure they can get it back and have it ready to go. Usually they get it back ahead of that, and they are fantastic to work with. All right, I think I made it in time. What questions do you guys have? Not messing around. I know I sped through some things, so, but being at the end of the day, I don't want to hold you here for too long over. So questions?
This is really important, especially in the work that we do. This is real life stuff. So thank you.
Yeah.
Any questions? Because this will come up in ITT and we might have to just call Kristen up and be like,
Yep.
hey, zoom into our ITT session.
Yeah, Steph knows where to find me. So.
So I have a quick question. So I'm just asking for myself.
Sure.
I saw like education about temper tantrum, right? And the information I think it's in STEM. Can I copy and paste on my?
No. Is it yours? Your information or?
No, it's from this website.
Oh, from the Knowing Notes website?
Use the knowing note in full, or can you take and put it into your after visit summary and print out to the family?
Because that's not my translation. It is a translation from the hospital. So.
Right. So what we ask is if you're using a Knowing Note, that you take that and you use it in its entirety, and we will have it, we can print it out and have it made for you so you can have the whole document. The reason I say that is because we know people are putting things and putting Knowing Notes in to their ABS, but that's like it's a whole big long thing. But we review our documents every 3 years. We know people are taking those documents, putting them into the ABS, and you may do it with the best of intentions, but then you change jobs or you go somewhere else. And when that document gets updated, that PDF that got put in for the ABS is not updated. So then you're not giving the most up-to-date information. So we are glad to help you in that. If you want it in like an education title, so the patients and families can have it to be able to go home with, like, we're glad to help you in any way. We just don't want to have different versioning floating around. And we want to try and control that and have the most up-to-date information. Does that answer your question? I know that's probably not the answer you're looking for. A lot of people want everything to be all in the ABS, but it happens more often than you think. People are like, oh, I'm trying to be helpful, I'm putting in the ABS, but like we found things in Epic recently working with IS team that are from 2012. Like there have been 2 different or multiple different iterations of that we've reviewed since that time. There may be updated information. So we don't want the patient and family to get way outdated information or conflicting information with what this person may give them. So we're trying to standardize that a little bit in that way. And that's why my answer is what it is.
Oh, sorry, ABS. Good job.
Oh, sorry, thank you.
After visit summary.
Correct.
V, like
V, yeah.
And I am kind of a stickler about this, and Elizabeth will call me on it because I don't do it every time, but I try to send the family out with that after visit summary after every single appointment. And my child's pediatrician does not, but thankfully she puts things in the my chart so that I can at least go back there and remind myself, what did we talk about? But I like to hand out the piece of paper as well, even if it gets thrown in the backseat of the car or gets walked on the way out. Yeah.
My apologies. Thank you for that question. Yeah. After visit summary.
So with that thought, are you able to use a knowing notes to attach as an email attachment? I mean, is that okay with you?
As an ABS attachment or
No,
as a
just
handout?
an email attachment. You can use
If you're sending it to a patient and family through my chart, is that what you're asking? If you pull it from Centerlink, sure.
their PDF.
Yeah, they're PDFs. Yeah, right. Yes, absolutely.
So the knowing notes are just accessible to the hospital staff, is that right?
Correct. Correct.
I'm not here going, oh, let me see, I want to.
Only because there are things that go with a conversation. I'm going to teach you how to put down an NG tube, but then I'm going to watch you do it. And I'm going to show you tips and tricks. And if you want to write notes on there, something like that, it's also kind of a liability. So if we have those things, yeah.
Information for the parent.
Yeah. Good question though, yeah. Other questions? Oh, well, thank you guys.
Thank you so much.
Yeah.
And you gotta walk out. Thank you.
I know.
Yes, I don't know. Oh, yes, yeah.